Hi everyone, welcome once again to Ace Podcast. It's another fantastic episode where we'll be discussing very interesting topic. And today we will be having a very amazing personality, someone who I've admired her work from far and also at very close range because of the limitless impact she's making in this space, especially when it comes to breaking the barrier, invalidating a lot of outdated norms, and doing that through some tailored communication. And that is Mrs. Vivianne, who is the managing director of Nigeria Health Watch, who focus on communication and advocacy in ensuring that misinformations are corrected and everyone have access to good and adequate information that could help them take a lot of informed decision about their health. Before focusing on the health sector, she has worked at some of the world's leading communication and research agencies in Europe and Africa. She has an MBA from the Gordon Institute of Business Science, that's University of Pretoria, and an MSc in Global Health Policy from London School of Hygiene and Tropical Medicine. She is an African Public Health Leaders Fellow at the Center for Universal Health in Chatham House. So, ladies and gentlemen, welcome Mrs. Vivianne. Nice to have you here.
Good to be here, Afeez. Okay. Good to be in your studio.
So today we'll be discussing very interesting topic that range from what we've always what has been one of the biggest elephants in the room, and that is the role of advocacy in influencing health-seeking behavior among women. We understand how a lot of studies has shown good correlation between access to information and the health-seeking behavior, and that intersection always leads us into the final health outcomes that we have at the end of the day. So I think the first thing I will ask is when we talk about the gaps between knowing about facility-based care and actually using it, in your experience, what will you say is the biggest driver of that gap between the access to information and the utilization of these services?
Okay, I think, when we think about health-seeking behavior, we have to understand when people are ill, what are the key things that they think about, or where do they understand they should seek care? Typically, for most people, you would think, okay, I need to get care from a skilled health provider, so a clinic or a hospital. But as we've seen in a lot of our work in Nigeria, access to that care has been very uneven. Often in communities, there is no health facility for women to go to. Women are often in many families their primary caregiver, responsible for themselves and their children. So when they're ill, you would think the first place they would go to is a primary healthcare facility. But in a community where there is no healthcare facility, then typically they would have to maybe go to the local chemist or pharmacy, the community pharmacist, or wherever. But in instances where there is a health facility, we have seen through our Community Health Watch work, the level of service delivery has sometimes been quite poor. So, for example, we have Community Health Watch reporters in Kano and Kaduna and Niger. And we have examples where women will go to a health facility and they go there to, simply immunize their child. And they don't even have a bed or somewhere to put their child on. And these are the very basic things that you would expect in any health facility. Mm-hmm. So this would definitely affect the quality of care they receive. Or if they go to a health facility, there's no health worker. Or the health worker there is stretched. So when they see all these different challenges, then they're less likely to go to a health facility where there is. And when they do go to a health facility, the service delivery they experience is sometimes poor, therefore, again, affecting their health-seeking behavior.
And that's very profound. And I think one big thing I'm picking from what you've said is, as much as we try to give the information and try to give a lot of orientation on why people should seek health care, if the quality of care they are getting when they finally get to the health facility is not matching the expectation, we are reversing the wind, because at the end of the day, it will be You've invested a lot making me to go to this facility, but when I got there, I couldn't even get ordinary medication. And that will continue to erode the trust that people should have in the system. And I think that's very clear. Thank you so much for that very, very insightful answer. So, and now in the conversation, from your lens, what will effective advocacy for health-seeking behavior look like for you?
I think, when I mentioned the Community Health Watch project, the reason why we intentionally embedded community reporters in communities, as you know, Nigeria Health Watch, we do health communications and advocacy, and some of our key outputs is our editorial. But we also realized that we need to also provide a platform for people in communities to share their experience of service delivery. And through our Community Health Watch reporters, who we have done significant work with in Kano and Kaduna and Niger, we're really pleased that what that has led to is through the stories that women share about their experience in health facilities, and we document them and we share these on our website. They now provide a platform for women to now say, I went to a health facility, recent stories we covered in Kano, where there wasn't even basic medication for them. But then you also realize that if you don't have a platform through which you can share your experience, then those who are responsible for making sure service delivery is optimum, how do they get the feedback? So one thing we did is having town hall meetings with the ward development committee. And for the first time, women are now seeing that they actually have someone they can speak to. Because typically when they have issues, who is going to listen to them? Who are they going to share their experiences with? And through the sharing of those stories, we're able to now also speak to the state ministries of health. Because they too, in a way, ironically, do not have that lens in communities. So by creating this platform and providing the feedback mechanism using the town hall meetings, they're now better able to understand, in this ward, this is the particular challenge that's being encountered. And through that, they're able to now provide a response, be it make sure that there are health workers there where there are none, or even something as simple as there's no running water. There's a health facility we reported on where there was no running water. And it's actually quite a simple thing. And the community actually banded funds together and they built a borehole themselves. So in a way, what you're doing with your advocacy is, yes, you're highlighting, you're spotlighting an issue, but you're also empowering a community to have the ability to solve a problem for themselves where they're able to as well.
And that's key. That's big on sustainability. And in sometimes the advocacy is not even just to the government. It's making people understand what stands between them and success and showing them the incentive for actually committing to results. And thank you so much, Dr. That's great. I think going to Nigeria Health Watch now, like I told you when we met in Kenya, Nigeria Health Watch, I admire what you do. I admire your person because we live in a world where it's a struggle for people to focus on one thing. People want to do everything. But Nigeria Health Watch has committed to using media and public accountability strictly as a tool for health system change, which is profound. Because I don't even want to imagine the amount of pushback and negative reaction you will get from the beginning. Anybody will ask you that why are you choosing the longer route? Why are you choosing the other route where you could just do implementation? Because it's hard to measure that on paper. Somebody would rather say, let me do implementation and distribute some commodity and say I declare 1,000, as against intentional effort to change how people think, which we know is the hardest thing to do. So when it comes to shifting health-seeking behavior specifically, what has the media advocacy been able to move that other channel could not? And where do you think we have those shortfall?
Okay, it's a good question because you're very right. As an organization, from the very onset, when we started, the premise for when Nigeria Health Watch started is there was a very clear gap in the way Nigerians even understand about health. If you think about how health is even reported, health is not an exciting topic. People do not open newspapers or buy Guardian or This Day too to read the health pages. Yeah. You buy the paper, you turn to the back. You're reading the sports pages or you're reading entertainment. So health was never really an issue that people understood or really put much thought into. And we know in many countries, let's talk about, global north, whilst as much as I don't want to compare, but just as an example, the health sector or what the government delivers in health has the ability to make sure a politician wins or loses an election. Because health is such an important thing to people. Because they understand that I have a right to health, I pay my taxes, so because of that, I should have access to health. In a system where we have a low tax base, so politicians do not feel accountable, or decision makers, to the people to deliver on health. And therefore, Nigerians never expect to even get access to health. So why should they even care? So by using our platform, we understood at a very early stage that as much as we say we're health communications and advocacy, we also want Nigerians to be champions for their health sector. So if you're in a community and your primary healthcare facility is not functioning, it actually should be. So how do you make sure you provide them with the information, provide them with the data more than anything, and provide them with the issues that they should be asking for? And so we made sure that from the very onset, we have our editorial that we publish on a weekly basis where we spotlight issues, but we also use our convening platform to bring together different stakeholders to really focus and discuss specific issues. A key one when I talk about convenings and why those are even important. Last week we held our maternal health roundtable, and we brought together the SWAP team, the MAMI team under the SWAP office with Ministry of Finance. And you realize in that room that the Ministry of Finance have absolutely no idea the interventions or the strategy the government is putting in place to address maternal health. So when you're talking about gaps in funding for maternal health interventions and others, who are the key stakeholders you need to be speaking to? We know we need to move away from just working in our individual ministries, because I know, like for instance, in Rwanda, you have the Minister of Health and the Minister of Finance sitting next to one another. We cannot make sure we have a sustainable health sector that is well funded, that delivers for Nigerians, if we do not have these different stakeholders who are sitting together in the room. So by that, it also means that Nigerians also have to be better informed about health. So unless they have that information, unless they're given the tools and the advocacy messages, then how else are they going to demand for the health that they need and that they have the right to?
And that's clear. So it's about helping everyone to take informed decision at the end of the day, both from the national level. And I agree with you. I think the biggest thing you do that I admire is helping people to even know what the minimum they should be requesting for and what they should be accepting should be. Because at the end of the day, why should health budget still be something we are discussing at this point that is not optimal? Why is it that people don't even have an idea of what the minimum service package they should be getting at the primary healthcare level should be? So, and yeah, I think with all of the work you do, almost every report of yours that I pick always provoke a lot of thought, which is how do we move from what's currently look like a crisis to where we should be? And maybe that will even push me to at least play the role of what people try to say. Oftentimes people say behavioral change communication is supposed to be something that should move the needle. But lately it's looking more like another industry that what you see is a lot of reports, but things are not moving, it's not translating into results. And the numbers don't move as much as we have a lot of funding going into advocacy. How will you respond to that, and what are the plans to actually change that narrative?
Behavioral change communications is complex because it's on multiple levels. Because what you're ultimately trying to do is, in the health, for instance, in health, is how are you going to influence the way people seek health? And a lot of it, as we know, as a country, is there are a lot of social norms that influence how, especially women, seek access to health. So let's think about an area that, for an organization like Nigeria Health Watch, we spend a lot of time with and we've done a lot of work in, which is maternal health. As we found, we did a report in 2018. It was a community-informed maternal death review to better understand why are women not going to health facilities to give birth. Because we know that, only about 40% of women give birth with a skilled birth attendant. Yes. A majority of women give birth in communities. Even the stat I've just told you, most Nigerians don't know, because
absolutely
we know we all live in our bubble. So most people assume that when a woman is pregnant, you go and give birth in a hospital. But actually, the majority of women do not give birth with a skilled birth attendant. And as a result, we've seen our very poor maternal health outcomes. And so we did it in 6 different states, and every single state had their different peculiarities. But one thing we found that was the same across many of the states is the reason why people don't give birth in health facilities. Yes, there's the service delivery level in terms of poor primary health care. But also in many communities, they prefer to go to a skilled birth attendant. That's also sometimes driven by cost, but it's just also driven by social norms. It's what generations of women have always done. We went to a PHC in Kano and looked at their ANC visits, and we saw that many women were coming for antenatal. But when it came to delivery, they had very low, a low level of deliveries in the hospital facilities. And the midwife there said, the reason why many women don't give birth in the health facility is, A, it's just not what they do. In that community, they've always given birth in community. So for a woman to go to give birth in a health facility, it's almost as if they don't trust the local birth attendant. But there's also the reality that before they can even go to a health facility, they need to seek permission from a male husband or brother or whatever. And if that person is not there, then the next person is their mother-in-law or otherwise. So a lot of these social norms are things we need to try to change or fix. And part of that means, who are the key decision makers in a household? How do you influence the husband that when your wife is pregnant, she should be going to antenatal? She should be, you should, if you can, you go with her. She should give birth with skilled birth attendant because this will help improve her outcomes. When you have a child, you should take your child for immunization. Yeah. So we often focus a lot of our advocacy and messaging on women. But knowing the realities of our context, we also have to speak to the other decision makers in the household, which is also men. And they have a large influence on the health-seeking behavior of women. So in order to change, when we talk about behavioral change communications, those need to also be tailored to the decision makers in households, which are also men, and not focus all our messaging, which we often do, just on the women.
Absolutely. And thank you so much. I love how you touch on the social ecosystem. Because for me, I think the big elephant in the room is, research has shown, we have the numbers, we have the fact that male involvement will always be a critical part when it comes to driving health-seeking behavior. But sometimes when I look at a lot of advocacy material, it looks like, I want to use the word in quotes, massage the ego. We still build it around the women, even though we know that no matter the level of information you load into them, they still need the spousal approval before they could get things done. I remember when we did some work in a state in Nigeria about family planning. After a lot of money has been spent, I think it's a 400 million USD investment that they've spent more than 380,000 and they've not gotten results. And with the remaining $20,000, when they approached us and said, what can we do differently? I said, if you spend 380 and you're not getting results, we can't continue to do the same thing the same way. So why are people not doing this past this approval? The remaining $20,000, let's use it to empower where you will find these men, the tea vendors. Go to the Meshai, bring them in for training, train them about family planning, then use the 20,000 naira for them to expand their business. And say, you know what, go and expand your business. We don't want anything in return from you. But when men come to you in the evening to take this tea, just discuss family planning. And the number started surging. So I feel we know that these men has a lot of role to play, but for one reason or the other, is there a reason why for one reason or the other we shy away from it and we still want to keep targeting the people that we know they can only hear, they can desire, but oftentimes they don't have that autonomy to take the decision. Is there a reason why we always design the advocacy that should be shifting? The advocacy, is there a reason why we are designing it to just preserve the men and to keep focusing on the women? Are there real barriers that is making us from getting the messages across to the men that should be taking it?
I think, you highlighted the issue of sexual reproductive health. The reality we know in Nigeria is the burden of responsibility. When I say burden, I don't mean it, in a negative way, but women are given the ultimate responsibility for sexual reproductive health. So a lot of the messaging is often targeted simply at women. But we know, realistically, it takes two. And messaging typically has not often targeted men. But we also have to think, those men, who are the people they influence? I often, we think, in our normal lives, Where do we ourselves get our information from? From our friends, people in our community, people who we trust. Somebody may say something to you, but if within your friends, people are not doing the same thing, look at football example. Most guys will realize they're all Arsenal fans because everybody's an Arsenal fan. There may be one outlier that supports another team. So who is the reference group those men typically listen to? In our culture, we know religion is a huge factor and has a big influence on people's behavior, whether it's health or otherwise.
Absolutely.
So traditional leaders, religious leaders, these have a huge influence on the behavior of men and also women. So they also have to be included in any messaging because they will be the ones to speak to the men in the community about, when your wife is pregnant, you should take her to a health facility. Also messaging around family planning. We know in some of the northern states, we don't really say the word family planning because ultimately, religiously, it's not for you to plan your family.
Exactly.
So you talk more births of child spacing. We did a policy dialogue about 6 years ago, quite a while ago. And I remember, one thing I remembered about it is we had some, I think he was from, I can't remember the organization he's from, but something he highlighted. It was from ARF. He was from ARF. And he said, when you talk to men about, when we say family planning, contraception, whichever, you have to also talk about the economic argument. That as a man, it is your responsibility to look after your family. And in that, you want to have the number of children that you can afford.
Yes.
Because if you're a good, responsible father, then you should have the number of children that your pockets can carry.
Absolutely.
So that's why you should, when your wife...
That's the first evidence that you love your family.
Yes. So when you have when your wife gives birth, give her time. She shouldn't be pregnant immediately. Give her 2-3 years to get her body to recover, because by her being strong, she can also look after you. So when you now frame it in, child spacing, not family planning, tell them it's about the economic argument. You as a responsible father, it's your duty to take care of your family by having a number of children you can afford. But one thing we also forget, I think, in the family planning space or sexual reproductive health, is what do people even understand about sexual reproductive health? We often look at it from just a health lens. We forget education. What is our curriculum teaching young people about sexual reproductive health? It is deficit in even avoiding the topic.
I agree.
For whatever reason.
I agree.
So, a lot of our work, we don't just sit and do it on our own in our office. We do it through engagement with different communities, by focus groups. So we did a focus group with teenagers and really interrogated their understanding of sexual reproductive health. And because of our context, we separated the boys and the girls because it was just a much more comfortable space for them to speak independently. And you find that there are so many myths and misinformation, what some of them said about how to avoid getting pregnant. For example, they cited Limca as a way to prevent getting pregnant.
And you wouldn't blame them.
They don't blame them because we look at, as I said, sexual reproductive health as an example, from just the health lens. But we forget that education is also important.
Yes.
Education both in terms of informing them about sexual reproductive health, about their bodies, but education also, when we look at the large number of girls who get married at an early age, education and also making sure that we keep our girls in school for longer. Because what that means is the girl is 16, 17, 18, 19. She's delaying when she gets pregnant or even gets married. And we know that that has an impact on their health outcome and also educational outcome. So we look at these issues, in the advocacy we do, and in the role of education and in the role of who are the decision makers. But we also need to remember that education, both in terms of in school, but also education in terms of from a social lens, is also very important.
And that's very profound. So I love the three lenses to what you said. The first one is, yes, we want to get the message to the men, but we need to always tailor the message for them to see a value in what you're solving for. Rather than, let your wife not be giving birth every month so that she will not die. She needs to be healthy enough to look at you. The two is we also need to be addressing the big elephant in the room. When people are educated, they are informed and they could take better decisions. I think the third piece I picked from what you've said is we also then need to be realistic on where do people actually get the information they use. Because the person that said Limca probably read something on Facebook and saw that this is it. So if we need to get this message across, we need to know where do these people access their information from, do some social listening, and use that to inform what the kind of information they have access to, and that's quite good. And I love the bit when you spoke about community and religious perspective to all of this, because what we've seen most time, especially when I go for health intervention, is the community head that said we should not do this, our religion leader has said we should not do this. And I would like to hear from you quickly what an accountable advocacy look like to you, because we look powerless when they say that. But from your lens, who is more of an expert in this field, what will you call an accountable advocacy?
I think, in advocacy, you'd mentioned before that as an organization, this is what we focused on. And if you want to measure impact or accountability, it's easy to do interventions because you can measure the number of children who are immunized, vaccinated, et cetera, number of nutrition projects you implemented. But advocacy is a much harder thing to measure, because you're now trying to influence people's behavior. You're doing your stakeholder analysis. You're looking at who are the people who have the power, who are the people who have the influence in communities, and you're taking your message to them to move a needle from A to B. And that message is not something that you do once and you say, okay, I went and I spoke to this traditional leader and that is it.
Yes.
What you are looking to measure more than anything is after you have delivered that message to the traditional leader, religious leader, community, whoever, then you go back and you look maybe in 6 months' time. Through the advocacy you've done, what has that changed? And this is when you now speak to people and understand, but before you spoke to them, so you almost like do a baseline. This is what we typically do, because that's the only way you can really measure how your messages make a difference. So what was the understanding of a specific issue? Then you now go back and literally ask similarly, and you now do another analysis to look and see whether you've been able to move the needle in your advocacy. So advocacy takes a long time. It's harder to measure. But impact, you have to set the metrics from the onset. What is it you're trying to move, and what is it you're trying to measure? And that's when you now go and use that as a framework to measure the impact that you've had. But one thing we have to also admit is when you do your advocacy, there's attribution and there's contribution. I think often in our space, there's too much attribution.
Yes.
People say I did this and I remember I was in a meeting once, and an organization said that because of what we did, we were the ones that pushed for BHCPF to be 1%. And I looked at this person and thinking, and this was the person, we were not in Nigeria. So when you're outside of the country, you can say whatever and nobody will question you because they don't know. Because of what we did, we were able to increase, push for BHCPF. And I just sat and I said to my colleague, you see, that is attribution.
Yes.
You can say that we contributed
absolutely,
through the work we did
absolutely,
to implement BHCPF. So we have to also be careful that we don't say because of what we did, we did X.
Yes.
All of it, all of us in the work we do, we're contributing collectively to a bigger game. Which is why, I always say to my team, Nigeria Health, we can do our advocacy communications, but we can't do it alone.
Absolutely.
And that's where the power of partnership comes in, all the work we do.
I agree completely. And in terms of organization that has actually been grounded in that principle of partnership, I think I give the kudos to Earthwatch. It's been, almost everything you do, you see at Nigeria Earthwatch doing this in collaboration with this, because frankly, no one person can solve this problem. And that point about synergy and collaboration will take me to the next question. And it's around, we're now moving to a place where both the donor and the implementers are only talking about one thing, which is digital health. And Nigeria Health has done a lot of work. You always work at the intersection of media, communication, and technology all the time. And maybe as we look to move faster, where do you see digital health helping us to accelerate the behavioral change that we want to see? Do you see any promising sign, or you think all of these are just buzzword and hype?
I think when you say digital health, my interpretation, kind of in work in the context we do, I would look at it from the lens of the work we do around social listening, where because obviously when we do our advocacy and we do our messaging, we have to use evidence to inform it. So through the social listening, we've been doing it for in fact, we started doing our social listening back in 2020. Do you remember during the COVID-19 outbreak? Nigeria thought we were part of a team that supported NCDC in doing a lot of the communications and messaging. So how were we going to be able to come up with those messaging if we did not know what people were saying about COVID at that time? What were people understanding? So that was really the onset of the work we really did around social listening. So by the social listening, basically what it means, we used to scrape all the internet, all the digital sources, and listen to what people were saying around a specific topic. That way, you're able to tailor messaging to make sure that if you're talking about, I remember when the HPV vaccine was rolled out, we needed to listen to what people were saying, because we know the perception of vaccines as it is, but the danger, HPV, people may be resistant. So what were people saying about it? And how can we use that information to tailor messaging around why is it important to take your daughter out to get immunized? How can we make sure that they're informed of that information? And we need to listen to what people were saying in order to tailor the messaging. So in that way, that's how, we've kind of used, digital tools. But in addition, in our community, I mentioned we do our Community Health Watch project. We have our integrated community listening project, which now uses triangulated information from the Community Health Watch work we do, from the focus group discussions, from the social listening. And through that, we do surveys every 6 months or so. So that integrated community listening has really helped us to better make sure that we're better informed about, health delivery at the community level. And that has now led us to develop, with support from another partner, MEA, to develop a AI dashboard, which really you see the map of Nigeria, and you're able to go into specific wards using the AI dashboard, which we hope to launch in the next month or so.
Awesome.
And you're able to better understand at this ward level, using secondary data like NDHS as well to triangulate, what are the issues in that community about immunization. And the information is not just data, but it's also qualitative. And that qualitative information is what we take from our community health watch reports.
Beautiful.
So you have the quantitative information from NDHS and our integrated community listening, but also the qualitative data now gives you that context around the data that you're seeing.
That's profound. And please invite me for the launch.
Yeah.
That's something I would like to be part of. And I love the bits you highlighted about social listening. One of the biggest problem I've seen in our behavioral change communication and advocacy work is we reach the easy target, but my problem is always this hard to reach population. They hard to reach men, they hard to reach women. We have the demography of women who are the hardest to reach settlements, and there are different efforts everyone is putting. But for me, maybe it's to hear from you that what are the strategies that you think will work most, or that has worked when it comes to reaching them, and not just reaching them, actually reaching them effectively, meaning beyond reaching them, we are changing the way they work and the way they think.
And we often use, when we say hard to reach communities, these are, communities that, somewhere like Kano, which is very spatially separated. It's a huge state. But communities and settlements, Zamfara, another one we've been to, these areas are quite spread out. And these are, what we call hard to reach communities, because that's where you often see the biggest deficits in healthcare delivery, education, etc. But we know we have to reach them, because these are the communities where you will often see some of the worst and hardest health challenges. I remember going to a stabilization center in Zamfara for one of the nutrition projects we were doing. And we were seeing mothers who were bringing their children because they were severely acutely malnourished. And they were bringing them there because at that stage, the best way to revive that child is to give them the ready-to-use therapeutic foods. But we also saw interventions in that community that were also teaching mothers about infant and young child feeding, literally showing them that in your community, you have all these different food items that you can cook that are actually quite nutritious. So as much as we say how to reach communities, we know they exist, but we still have to advocate to the government, because in that community, the work that was done was sadly funded by development partners. And when you ask them, how is government supporting you, the government is nowhere exists. So the advocacy is also to the state governments to make sure that in those hard to reach communities, where, there's less investment, there's less incentive, that we also reach them. because that's where we see some of the worst health challenges. And, you know, if we look at something as simple as health security, if you have an outbreak in a community, a hard-to-reach community, how are you going to be able to stop it if you have not put in place the systems, put in place the structures to address that health emergency? So those hard-to-reach communities, as much as they seem hard to reach, they still have to be part of any healthcare delivery in any state. And this is where I think a lot of our advocacy comes in. And also making sure, like with our Community Health Watch project, that we have people who are in those communities, not, you know, coming in from the state, coming in from the towns, but actually embedded in those communities. Because we often find that, you know, in communities, those who live in those communities have the greatest vested interest in ensuring that things function. So it's a mix of working with local community-based organizations, but also using that voice to also speak to the people above, the decision makers who can influence change.
Thank you so much. This is very helpful. I picked that from, if we want to reach the hardest plan, as long as other strategy get to them, we could also leverage those other interventions that get to them to ensure that advocacy is part of. Advocacy is not an add-on, but it's a core part of our implementation. Thank you so much for highlighting that. I think my last question will be around scale and accountability. One thing you've highlighted is the role of partnership, how critical it is to collaborate. And the point is, we've all agreed that one person cannot do everything. It has to be some community coming together. Like, we have to call ourselves community of partners, and everyone come together to try and fix it. What would you say we need to do if we need to bring more people to the seat to accelerate the win around advocacy, especially for maternal and newborn health? Two is, who do you think is holding the biggest needle? Is it the donor? Is it the government? Is it we, the partners? So that's like two questions in one that I want to use to wrap up this conversation, which has been very exciting, by the way, is what do we need to do if we want to bring everybody to the table? If we want to scale, we need to come together. And two is, who has the biggest role to play to make that happen? Okay. Thank you.
I think the first one, if we want to scale, we have to put aside what we often find in our sector is competition. We need to cooperate. Yes. So I always say cooperation. None of us can do it on our own. Some organizations feel, okay, I'm, in maternal health. I remember when we did a roundtable around immunization, and someone said to me, Nigeria Health Watch, you're now in immunization. And I thought, hang on, we don't own any issue. No organization owns maternal health, owns immunization, owns nutrition.
Absolutely.
We can't do it on our own. So the first thing I'll say is cooperation. We're better together and we're more together. So scalability is easier when we work as organizations together, because every organization has this area of expertise. So you bring your area of expertise, you bring yours, and we work together to solve one issue. Next, you asked who has the biggest power. I think citizens. I remember Truth Judonwo said in a TED talk that the highest office in the country is the office of the citizen. We forget that. We forget and think that it's the decision makers, those who drive around in black cars, have the power. We, the citizens, are the highest office in the country, and we should use our voices as much as we can to push for what we need as Nigerians.
Thank you so much. That's profound. So we need to come together. That's certain. The biggest role is the citizen, and I like the how practical that answer is, because when you say the citizen, that means if you are a donor, you are still a citizen. If you are an implementing partner, you are a citizen. So we need to own our own solution. And thank you so much, Dr. Thanks so much, Mrs. Vivianne. This is very helpful. And thanks to everyone that has stayed with us till this time. Please don't forget to like, comment, and share, and engage as much as possible. For sure, this is a conversation starter, and we will look to continue this conversation on how can we continue to leverage advocacy as a tool to drive meaningful change in stopping our women and children from dying. How are we ensuring that the biggest decision maker, the husband, have the information to help them allow these women to take informed decision? And for anyone that has been listening since the beginning, Mrs. Vivianne, I want to hear from you. What is one takeaway you want them to, what is one power message you want to leave for them, for everyone to continue to ponder on as we all look to build the kind of world that we envisage? I always say the word I envisage is when my children hear that there was a time that women die when they are giving birth. The only way they could relate is they saw it in the textbook, because it's no longer happening. I love the way that when we are out of the country, when you're in US or you are in London, and you see a woman that is heavily pregnant, the only thing you are worried about is, will it be male? Will it be female? Will it be a boy or a girl? You are thinking about it from the lens of, will it be multiple, or a single birth, or a triplet, or a quadruplet? Those are the problems you have. It's only in Nigeria that delivery looks like an emotional story. When you see pregnancy, the first worry is, in fact, it's always prayer. We wish you safest delivery. I don't get that prayer when you see a pregnant woman out of the country, because the healthcare system is already designed for safe delivery, right? And that's the word I look forward to. So I don't know what call to action you want to have to all our listeners as we wrap up this conversation.
I think for our listeners, one thing I would say is we have small windows of opportunity in which we can push to influence the way healthcare is delivered. And as I said, we underestimate the fact that the most important office in the country is the office of a citizen. Yeah. So, through the work we do at Nigeria Health Watch, focusing on health communication and advocacy, we really aim to inform Nigerians. And I hope that people use that information, make sure that they're informed about health, understand that everybody has a right to health, and make sure that we demand from our decision makers that we have the right to health. So when people have poor health outcomes, that we don't do what we normally do, which is, it is God's will. Because I can tell you for free, as you just said about maternal mortality, when a woman dies in childbirth through preventable causes, sorry to say it, but it's not God's will.
Yes,
there were reasons that women died.
Absolutely.
And we should stop accepting it as it is what it should be.
Absolutely.
Because actually it shouldn't. Because that same Nigerian woman who's pregnant can cross the border, get on a plane, and she won't die.
Absolutely.
So we have to start asking questions when things happen that shouldn't happen. And every Nigerian should always remember that they have a right to good health.
Thank you so much. And thank you, Ms. Vivianne. This is very, very helpful. I think that message is clear, which is health advocacy is the responsibility of everyone. So to your neighbor who is pregnant and has refused to go for ANC, it is your job to prompt them to take informed decision. So that will be the closing bit of our podcast. For this episode of our podcast, we really appreciate your time staying till this end. Thank you, Mrs. Vivianne, the CEO of Nigeria Health Watch. Thank you so much for bringing your expertise and a lot of insight into today's conversation. It's been a pleasure speaking with you in the last 40 minutes, and we look forward to continuing this conversation and, of course, applauding and cheering on all of the amazing work you are doing at Health Watch. We're happy to know you. We're happy to have partnered with you, and we look forward to a lot of partnership in the future. Thanks for doing the hardest work of changing the health-seeking behavior and accelerating how quick we can get to universal health coverage in our country. Thank you so much for what you do for us continent-wise and globally. We look forward to speaking again soon.
Thank you very much. It's a pleasure to be here.